Well, hi, everyone, and welcome to episode 3, Urinary Incontinence. No, we're not kidding. Let's talk about it. I have to tell you, I just love that title. We were just talking about that. And I just want to welcome all of you to this series called Listen, Learn, Explore. And this is a new venture for Pioneer Network that we're trying. And as some of you may know, it's based on a podcast about a topic where people can listen and learn, and then really to explore this more deeply, what the issues are with our podcast speaker, Rosemary Laird. Dr. Rosemary Laird. And I want to welcome the folks from SENI, Michaela and Deanna, to our conversation as well, because SENI is sponsoring this event, and we're just so happy to be partnering with them. They joined with Pioneer Network as a corporate sponsor, so we'll be working with them more in 2021. But as I was talking with Michaela and Deanna and Dr. Laird, one of the things that we talked about is how we just want to normalize some conversations that we have, especially in long-term care. And one of those conversations is about incontinence. And so Seni and Dr. Laird have produced and developed this great white paper that we're going to be talking about and sharing with all of you. But we also just wanted all of you to participate in a conversation where we could all talk. So I want you to know that this is a very informal event with all of us. And Joan Devine is on as well. Joan is our Director of Education for Pioneer Network, and she's running the controls. And I'm Penny Cook, and I'm the President and CEO of Pioneer Network. And so we just want all of you to be part of the conversation. So Dr. Laird, I'd love for you to introduce yourself to everyone.
Thanks, Penny, and hi, everybody. Yeah, so I'm a geriatrician, about 30 years of clinical practice in all different settings, taking care of I call them the 65 and betters. That's my crowd, and have really just enjoyed my time as a geriatrician. My clinical expertise in the clinic has been cognitive impairment. And I've been involved in taking care of patients with all forms of dementia across the whole continuum of care, including long-term care. And of lately, I've been more and more interested in sort of taking all the experience I have of this life lived caring for older adults and learning about the multidisciplinary range of other dedicated professionals who are out there and like-minded, have been spending their time caring for older adults. And we all really want to do a really good job for these people. So I've been looking for different opportunities to try and increase awareness and information and just share what I've learned over the years. And so not long ago, I stumbled into learning about SENI and met my now good friends and colleagues from there, Deanna and Michaela, and found a very similar mindedness around this topic of urinary incontinence and the range of need for raising awareness and helping really elevate the care. And they introduced me to Penny, and the rest is history. And then Penny and I came up with the title, and we just decided, yeah, we're going to go for it and put it out there and put this topic, that's a topic, put it out there and get some like-minded people involved in the conversation. So I'm very happy to be here and look forward to it.
Well, thanks. And I think that, one of the things I got so excited about this topic too, because I'll share with all of you that my family is experiencing issues. My stepfather, it has urinary incontinence and actually fecal incontinence as well. And so my mother is caring for him. And so, this topic is just personally near and dear to my heart too. And for Pioneer Network, one of our goals has always been not only to make sure we disseminate best practices and learn from each other about person-centered care, but also to ensure that we're letting people know about products and services that align with our values. And that's kind of how all of this developed. And so, Dr. Laird, one of the questions that, I know that people have been asking us is, why is Pioneer network talking about urinary incontinence. How does it sort of fit in with this person-centered philosophy that we try to put out there? And I know when we talked about this on the podcast, you shared your thoughts about this. So it's not only the Pioneer Network wants to push this out, but you had some thoughts of why it was so important too.
Right. So Penny let me kind of riff for a while on the podcast. I kept thinking she was going to cut me off, but she let me go on and on about it because it is really important. So one of the kind of hallmarks of geriatric care that I've come to really hold almost, fundamental as the beginning is the reality that every one of our patients is an individual, and you simply cannot use their age, certainly, or any grouping of them and come up with the solutions to their challenges that are facing them. And I think urinary incontinence is one of the areas where, especially in the congregate and senior living setting, this is one of the areas where there's been a lot of, I call it groupthink and group care for this particular symptom. And so that's really what got me thinking that it was the right topic to allow us to really kind of infuse some good principles of geriatric care into the senior living and the conversation in the congregate setting, because there's some good principles around. You can't group them all as a group. You need to be looking individually, because as we all get older, there's our health history that we've brought forward. There are things that happen to most of us as we get older. And then there's a combination of other factors having to do with lifestyle and choices and circumstances that all go together and create the person who needs some attention. So I think that was my initial interest, was using this topic as a way to really bring some geriatric principles of care forward.
Yeah, I think that's such a cool combination of really why you got into this more. And Donna and Tony, before we go on, because I mean, you've probably heard, we could talk forever. But do you want to ask any questions right now, or anything that you're really interested in getting out of this, next 45 minutes with us?
Well, I'll jump in there. I am not a provider or a clinician. I work for a quality improvement organization, and so I interact with the skilled nursing facilities. And I've been with the company for 20 years, but I've been specifically focused on long-term care for the last 9 or so. And in the quality measures that you look at, urinary and bowel incontinence is a huge deal. And it's something that it's like 76% of the residents are incontinent. And it's like, oh, that's okay. Well, no, it's not. And so I want to figure out how to support them in actually addressing it as an issue and helping to support their residents in having dignity and quality of life. And so that's why I joined this. I didn't realize it was going to be this little circle kind of thing. So I don't know, I'm being selfish in putting that out there, but I don't know how to get them to focus on that, because they're so focused on other things. And that's, to me, like, Dr. Laird was just saying, this is a fundamental thing that's part of dignity. Nobody wants to be incontinent. And so to like, oh, well, there are centers that I know of that when somebody's admitted, they give them a diaper, whether or not they're continent, and they expect them to just use it because we don't have time. And that to me is horrifying. And how do I as an outsider step in and say, that's not okay, and you guys need to do something better? And so that's why I joined us today, because I was trying to figure out how to do something about this. So
you're not being selfish.
I'll step off my soapbox now.
I know, it's great.
Yeah.
This is Tony, and actually Donna Thorson, I think I'm also with the QIO. I remember working with you in the grade 8. So it's like, I never did get to see you. And so it's like, oh my gosh, that's who I was talking to all those, like in the last scope of work.
Yes.
So I have been a well, I've been a CNA, I've been a director of nursing, and I've been an administrator. And now I'm working on quality improvement as Donna is with the nursing homes. And so in, in all of those aspects, urinary incontinence was always very important. And Donna said it, I can't say it any better, that it often gets pushed to the side. It's not a priority. And I just think about myself, as I'm getting older, I don't know where I'm going to end up, but I would sure hope if I am in the nursing home and I'm continent, I get to stay that way. I don't want somebody to take that away from me, because we already lose enough when we go into a nursing home setting. So I'll just reiterate what Donna said.
That's so interesting, that you know each other, that's what we find on some of these things. And I think that's so cool. And it's so funny, Donna, that not funny, but so interesting that you brought that up, because one of the things that we talked about on the podcast was, that this whole conversation isn't just about incontinence, it's about maintaining continence. And also we talk about, getting to the point of maybe, and I don't know if I'm saying this right, redeveloping continence as well, but then also the fact that it's not one size fits all. So Dr. Laird, I'm going to turn it over to you, because I know there's so much you want to say about this.
Yeah, I know. I'm very excited. But I just want to make sure, did the other individual sign out? Because I don't want to skip someone.
It looks like she did.
Okay,
Yeah.
okay. Well, so then with our two QIO folks, you are just like sent from heaven for people, for myself, I'll speak, but I'm sure the rest of the group. So yeah, this is wonderful. And what I'm going to say first, so I don't forget, is that I think both of you, I hope, and I'd love the feedback from both of you, given the way you are approaching this. We designed the white paper. I kind of hoped it would be looked at by people who have an interest in quality improvement. I mentioned earlier, part of the interest is getting some good principles of care about older adult care, because those align so well with Pioneer, of course, that person-centered care, but getting some of those out there using the vehicle of urinary incontinence. But it is very much then supposed to be a vehicle that allows someone to start the raising awareness process, educating, and then leading someone to have some tools to implement. We use some clinical examples, and we also use a plan, do, study, act kind of methodology to give them the ideas around being creative with how they take this information into their own care setting, so that they learn a fact, learn a way to help their patients, and then look to see what their ability is to make a change, hold themselves accountable to that and to their patients' well-being, and move forward with the quality improving on that basis. So we really intended it to be a living document. And I'd be real interested to see what you all think, because that's been the intent. Also infused in the book, in the white paper, is this idea that Penny alluded to earlier, and that is that product selection. Once we decide someone does need some help, we've maybe reduced their incontinence by 50%, but they still have some potential. Can we provide them the product that leaves them the most dignified, the most, normal, if you will, so that their day-to-day quality of life is maintained, along with the health, their skin health, their, urinary tract and digestive system health. So focusing on those things, product selection is a whole new ballgame. And many of these facilities, especially maybe the one you said that hands out a diaper at the beginning, I'm sure they're one of the places I talked about in the podcast where the cabinet is labeled SML, and that's the only sort of thought that goes into the product. So the white paper it has some aspects that could even allow product selection and learning about proper products in 2021 to be part of the quality improvement, because I think right there is something that we could improve tremendously. So I think, your backgrounds are extremely important to be in this conversation. I think it's great. So glad you're here.
And just so you both know, so if you look in the chat, Mihaela has put in a link to the white paper so that you both have that. So please look at that.
I don't have that in my chat.
We
No?
will email it also after. I can try to attach it again, but I will be happy to email after the podcast as well.
Yeah, and I
Thank you.
think what we should probably do is email that to everyone who registered. Would that be okay?
Yeah.
And then I'm thinking, and Mihaela, you and I can talk about this, about putting it up on the website too with the podcast so that.
Yeah, definitely.
Yeah, because I think that that would be really helpful, Donna and Tony, and also to, share with your QIO colleagues as well. But Dr. Laird, can you talk a little bit about what we talked about maintaining continence and sort of also, like Donna said, and I think sometimes, let's say people have been in the hospital, they're moved to the nursing home setting, they're already labeled as being incontinent. And then especially that creates one of those situations where, okay, so this person's just going to remain in the nursing home labeled as incontinent, even though maybe there are some things we could be doing, right?
Right. So I'm going to take a little bit two-parter on that, just to get some key points out. And what becomes important to understand about continence is the anatomy and what happens to our bodies as we get older, and the factors that make people incontinent. And so we won't have time for that all today, but that's part of educating staff, for example, and educating people about this problem. That's part of what we need to do, in part because that often leads to some solutions that can be very effective. So, example, as far as maintaining continence, and I know Tony said she's looking out for herself and hoping, and I do the same thing. I learn all this stuff I'm learning as being a geriatrician. I've got a file of the stuff I'm going to make sure I do. Well, this is one of them. And it has to do with the fact that there's two key things that play a role in an older adult maintaining continence. And it might surprise you, but it's your physical strength and avoiding frailty. Just generally, everyone always thinks I'm talking about your bladder, but I'm not. I'm actually talking about your general physical strength, because there's a direct correlation. The weaker you are, you guys know that test where you have someone stand up while they're with their arms here. There's a correlation between that and incontinence, because there's a correlation between overall frailty and incontinence. So the moral of that story is keeping yourself physically strong is one of the key things that'll help maintain continence. The second thing that's often overlooked is nutrition and hydration. And in the long-term care setting, I think it's horribly overlooked, and we need dietary at the conversation. We need the nutritionist at the table talking to the people working on the diets and working on the monitoring of the diets, both food and water. You guys know fiber and water are sort of the recipe that patients need. But constipation is kind of the quiet, sort of silent urinary incontinence maker for many, many of these patients. So raising that kind of awareness, and you often think of the CNAs as the most critical people for the patients with urinary incontinence, so they can get them to the bathroom okay. But I try to point out to long-term care groups that I'm working with that you can't just limit it to the CNAs. You've got to get the dietary there, you've got to get your physical therapist there, and it's the whole effort that really makes people able to stay continent as they age. So I think those are kind of two big things that I would say, Penny, if you're trying to keep someone continent, those would be things to pay attention to. And then, of course, there's complications that can come in. Someone can have a condition of their GI or urinary tract that creates problems. They can have cardiovascular problems. They can be on medicines. All those sorts of things are kind of on top of it. And we can have conversations, but there's a whole set of things that would have to be done to make sure someone's not put into a condition of incontinence from some other factor. And some of those things can be fixed and some can't. And so that goes along with the care of that individual. Now, to your point about the person who came back from the hospital, right? Wasn't that the next part? Yeah, that one just irks me to no end, because I can't tell you how many times I've been rounding and they tell me that's the story. And it's worse than just thinking everybody has incontinence, thinking everybody who comes back from the hospital needs to keep their catheter forever and ever. I don't know which is worse, actually. I'm going to put them both together. They're both terrible. So no, that's, fortunately, I don't see that as much anymore because we've gotten the hospitals a little bit better. I think it kind of has backed up. But if you do see that, you got to check the medical rationale behind it, but rarely is there a sound rationale for leaving a Foley catheter in, for sure. So those need to come out. And at the core of helping an individual return to continence are the things I just mentioned that have to do with maintaining continence, right? So it's usually that they're physically weak. Now, in addition to that, the presence of that catheter also means that there's been specific change to the pelvic floor muscles. So those are the perfect patients to have Kegel exercises done. And physical therapists can come in and help with that specifically, and should be. That's why your physical therapist should be brought in, even if they don't want to. And it's not a given that the physical therapist in the building is going to want to or know how to help with Kegels. So that's a little bit of a challenge. But in any event, and then getting their nutrition, getting their general strength, getting their pelvic floor muscle strength, and then getting their nutrition and nutrition and hydration back up to where it should be, are usually things that'll help you get that person from Foley dependent to continent. As long as their mobility is okay. Didn't really talk about that, but mobility is a big factor, of course.
So physical therapists help with Kegels in some cases?
Mm-hmm. Yeah. Now, in some facilities, some occupational therapists, but often there's physical therapists, and there's a kind of a subset of them that get trained in urinary incontinence rehabilitation and pelvic floor rehabilitation. Even for some fecal incontinence, you can have, so men can get trained in Kegel as well. And for fecal incontinence, the therapist can also work with patients, and that can be partly helpful. I would say in my experience and what the data would show, they are less helpful for fecal than urinary, because the typical reasons for fecal are harder to overcome with those exercises, but it can be part of it.
Well, I have to say, as a nurse, I've never really thought about. I've not made the connection, a natural connection to the rehab team as part of a continence issue. So it seems like we need to get this message out to a different audience than we've ever thought about getting it out to. What a great aha. And I also have to say something you said and something Donna said really made me think, Dr. Laird, where she talked about the community that just automatically gives you a diaper. I think something that is even more common is, and this gets talked about a lot when you're talking about mobility, is that organization that automatically gives you a wheelchair. And then we unintentionally create dysfunction for people. And again, that's another piece, as we're arguing why that's not a best practice. I think having that additional information about it's not just impacting your mobility, but it's impacting your continence. I think the more reasons for saying that's not a good practice, the better we can promote a better practice and a best practice that is, promoting mobility.
Well, to take that even a step further, Joan, is what happens when you come from the hospital to the center and you're not allowed to get out of the bed until therapy sees you. Right?
I am so with you on that, because as a nurse, I find that kind of insulting that you think that I can't make that clinical judgment.
Right. And that's, I mean, that happened. This is a personal story for me. That happened to my brother, who was able to walk with a walker when he left the hospital and then went to a center and laid in bed for 3 days and has never walked again.
Wow.
So, hello, right?
Yeah.
So then you throw on top of that any medications they're taking, like Lasix, right? And the staff gets fed up with having to change briefs or the bed or whatever because you're incontinent, and it's because you're taking medication and they won't let you out of the bed.
Yeah. Well, one of the things, yeah, those are all really important points. And I had not heard of the wheelchairs being, you know, provided that readily. I mean, it's, yeah.
I think it's a
Well,
product
a
of,
lot of centers have that policy that until you've been cleared by therapy,
That I've heard, yeah.
you will be using a wheelchair.
Yeah.
Right?
Oh, I
So
see.
yeah. Well, and I think, I was gonna say, I think the other factor is, especially in a more traditional home with the big long corridors,
Yeah.
someone who could easily get in a home setting from their dining room, from their bedroom to the dining room, can't do it in a community, or it takes an incredibly long amount of time in a community where you're walking hundreds of feet instead of 15 feet, which is the norm for most people. So I think for that reason, that wheelchair becomes a convenience. We start out thinking we're doing something nice for somebody, but in reality, we're creating mobility issues for people.
Right. Yeah. Oh, I definitely think there's a time, you know, it all boils down to time per patient, and things that take longer are not as likely to happen. And that's really one of the things we did with the white paper, was tried to put ourselves in the shoes of a busy, you know, nurse or CNA or therapist or anyone, and tried to give some some knowledge that can be very readily, you know, brought up and used at the bedside, and some ways, even around product selection, to be able to make better decisions more efficiently. And I think that that's a big part of it, because you're not going to change. You're going to maybe teach someone something, but you're not going to change their care unless you give them something to do with that knowledge that's easy and fits into their workflow that they believe is what they need to do to, you know, keep everything going as it's expected by their management. And so we're glad people from QIO are here. Often I find that and you guys tell me if I'm wrong, but the QIO world often includes the administration of the facilities. And to me, that's a big, big part of this, because the whole stigma, the whole, you know, desire to be person-centered, to really promote quality of life, that does represent a change in attitude, and it needs a culture that's developed towards those principles of care. And so I think, you know, I'm hoping that, do you guys have access to the administrators who can be influential if they can get educated about this too?
We're trying something unique as a QIO, or at least I think it's unique. We haven't heard of others doing it, but we actually, you know, when you think about the care of a person in the nursing home, who is the person that spends the most time with that person, that knows that person the best? That's the nursing assistant. Mm-hmm. And they play a key, pivotal role in all of the health outcomes that a resident has. And so we're trying to figure out, we have a program now, it's called Frontline Forces. And we've developed some educational opportunities for nursing assistants, and we're trying to figure out how to make sure they get that information, because we're also trying to figure out how we can engage with them directly, which is, we have like administrator and DON and MDS and social worker emails and names, but we don't typically get the CNAs, because for one reason, most of them don't have email accounts at the nursing home. They're their own personal email. But we're really trying to think about and really trying to figure out how we can touch them and empower them with knowledge and better skills to be able to take better care of the residents. So I'll just add that as a.
I think I'll just chime in for a minute, but as I'm listening to everybody on this, and I've seen this in a lot of the nursing homes that we've been in, I think too, we have to reconnect administration, the bigger the chain goes, to the front line, because we see it all day long with a big disconnect. And I think patterns and behaviors become the norm. So you typically look at a 7 to 3, a 3 to 11, an 11 to 7 schedule, and everybody clocks in and they do what they're supposed to do, and they're in that rhythm. But there's got to be, and I get it, because you have a nursing home and you've got a business to run, and that's one side of it, but you also have people, and with people come dynamics and come variables, and there has to be some type of room for the variations to come into play. So if you're, why do we round every 2 hours? Because that's what we do. Do we still need to do that? Maybe not. But will we ever change? We're hoping. That's one of the things Mahala and I focus on with Dr. Laird and Penny on this. Let's change it up. Let's not just do something because that's what we do. That's what we've always done. And I've seen it with some caregivers that, as we know, there's a staffing shortage. That's a big part of the problem. So now you have accountability for more patients, less time, more stress. Well, the tighter that gets, the less variation. So if we're used to helping to assist someone with toileting, which is great, and somebody's off schedule, I mean, everybody, us on the phone, right? We might say, oh, we take lunch at noon and we'll use the restroom. But if I have to go to the bathroom at 9:30, I'm going to find a way to go. We have to have that expectation, right? No matter what age we are, that there's got to be some variation to keep people continent. But what I've seen sometimes in the nursing homes, and there are great ones out there, and then sometimes, like anything else, they're not so great. But I do think it's key to bridge the gap between administration, CNAs, and say, yep, we have to have structure, but we can't be so rigid that if Mrs. Smith says, I need some help, that CNA can't look at their watch and say, I'm sorry, I'm headed out, but they'll get with you in an hour because an hour is too late and they become incontinent. So that's just my 2 cents of what I think needs to change, big picture.
Yeah, I think that's a great point. As I'm hearing this, and I think especially for Donna and Tony, maybe it's a question to Donna and Tony first. What can we all be doing in this world to help support your work on the QIO level? And I'll tell you, I'm a former QIO employee too. I used to work for Telegen. So Tony and Donna, I'm curious to know which QIOs you're with as well. But how can we support you? The white paper, I think, might be a good place to start so that you can share that with the homes that you're working with. And like I said, maybe with some of your other QIO colleagues too. But I'd be interested to see, like, what else do you need or could we do? And Dr. Laird, if you have ideas on how, we could support the QIOs in this work, because I'm so glad you're both on as well, because I mean, when I think about it, you're reaching a lot more homes, than probably we could ever reach.
And it's accountability. I want to hear from Tony and Donna. I didn't even want to answer, but I couldn't stop myself. Because what over and over and over my whole career, one of the big things that I think makes the difference with any medical care, but for our patients in long-term care and senior living especially, is many of the medical interventions that they're offered or someone thinks would be helpful to them, they may be started, but there isn't anyone watching to see what the effect is. And they don't have that advocacy, you know, of a clinical follow through often. And that's where I think QIO is so important in this arena. So I'm going to be quiet because I'd love to hear what you all think, you know, we could do, because I think that's the missing link that could take it and really make a change after, you know, many years of things not changing.
Well, first of all, I work for Comagine Health, which used to be Health Insight and Qualis Health, just so you know who I work for. So we have 6 states, but we also have a national presence because of our care review, care management part of our organization, which I'm not all that familiar with, but they're like in Alabama and Mississippi and everywhere, right? But when I think about the challenge for this, so like I thank you, Mihaela, for making sure that we had this document. I opened it up and it looks awesome. And the first thing that caught my eye was the diary. And I know that that's something that's recommended. It's a best practice to do when you have new admissions, to do a diary for everybody, just to see what's going on, right? It doesn't happen because they don't have time. I had one director of nursing services who believed very strongly in it. And she says, we absolutely have time because it saves time later on. So you will do it. But that's one out of, right, hundreds of centers. So I think it comes back to what you were saying, Dr. Laird, that administration has to be bought in, that this is important. And unfortunately, if we can't tie it to reimbursement, then it loses importance for administration. And I'm not saying that to be cynical. I'm saying that because that's the business model, right? Administrators that can't keep the census up and they can't keep profit lose their jobs, because that's what, unfortunately, our senior care is all about. But you know, you look at, there's this belief system that as you get older, you're going to be incontinent. And so that myth is, I think, the first underlying fallacy that drives this whole problem, is that incontinence is equated with aging. So if you're 80 years old and you fall and break your hip and you end up going to the hospital for surgery or whatever, and then you're transferred to a skilled nursing center for rehabilitation, they're going to assume that you're incontinent because you're 80 years old, not because of whatever else. And they don't even ask sometimes, you know, this whole thing about let's talk about it. They may ask somebody, are you incontinent? And they may say, well, no. And they must be lying, because people lie about that. Nobody wants to admit they're incontinent, rather than investigating, well, what about when you sneeze? Or what about when you laugh? Or what if you, you know, bend over suddenly? Or what, you know, I mean, that sort of thing. They don't investigate and ask questions that way. They just say, are you incontinent? And then they assume that the person's lying because you're 80 years old. and so I think that's one of the problems that exists in the world. The other is back to what we were saying before about staffing and the time that's involved. So really, what would it take to do a bladder, bowel and bladder diary for 3 days? Well, it really probably wouldn't be that big a deal. In some places now, actually, I heard about this from a colleague who's working on the National Echo series that's going on right now. They had a center share that they have what they call a concierge CNA, who's assigned to every new admission. Well, what the heck? That person could definitely be doing the diary, right? So I think that we have to start to look at how they're getting to know their residents when they're first brought into, live in the center, whether it's short-term or long-term, and reinforce for them that this is about person-centered care. and quality of life. And if the administrator could see that by providing this level of care, that they're going to avoid other repercussions for incontinence down the road that impact on things like pressure ulcers, right? Skin starts to break down because they've been sitting in urine or feces for a while. Now they suddenly have a pressure ulcer on the coccyx. Oh, well, that's not good, right? So I think that piece is missing. They don't see that because they're not clinicians. And the nurses might know and see that, but they don't feel like they have the staffing to be able to do what they need to do. And that takes away the flexibility of being able to do the relationship kind of thing of they need help right now. And so, yes, I know I'm scheduled to give Donna a shower, but I need to go answer this call light because, Joe needs to go to the bathroom. So, it's that sort of challenge that administrators don't see. They just want to make sure the work gets done and that everything looks good. Does that make sense?
Yep, perfect sense.
So that's the struggle that I've had and seen, but I don't know how to make that change in the leadership's view of what's going on with us so that it provides the support for the clinical staff to be able to do what they need to do to make sure this doesn't happen. And, I did a whole learning series on preventing functional decline because that's a huge deal. If you can prevent that, then you prevent a lot of things. And I had no idea that it was linked to continence. I wish I'd known that at the time, Dr. Laird, because I could have thrown that in there too, right? But, that to me is the challenge for what's going on right now with COVID is that I'm terrified that we're going to have people that have lost a lot of ADL and mobility skills because they've been trapped in their rooms. And some centers have not figured out how to keep them engaged in a meaningful way to prevent functional decline. So what's going on with that, right? So to me, it's all kind of a mesh with each other, but it does come back to this. What's the administrator's take on what their job is? And what's the goal of the center?
And this is Tony. I work for the Superior Health Quality Alliance, which is Michigan, Minnesota, and Wisconsin. And we also, we're a consortium. We have eight member organizations, which not only includes the 3 QIOs, but also 4 hospital associations and the Midwest Kidney Network. So, and just to take on to what Donna was saying, the other things that we see, at least in, it was happening before the coronavirus and continues to happen, but turnover in administration, director of nursing and nursing home administrator is terrible. And what happens a lot of times is I think you get some good things and you start to get a sync going and then somebody leaves and it's like they're starting all over again. And so it's like, how could you build a system or a culture so that when someone integral leaves, everything doesn't fall apart and have to start over. The other thing I think about, you made a good point too about the administrator understanding the value of having a good program around urinary continence. I remember when I was at a DON and we had a fair amount of folks on medical assistance, we were paying for their incontinence products, and they can be expensive. And so just yet, not only is there are all the other quality of life issues, but there's that cost factor, as well that, that factors into that. So.
And Tony, and kind of in response to what you said, prior to coming to Pioneer Network, I worked as basically the director of clinical services for 2 different organizations in the St. Louis area. And I think one of the opportunities that a lot of communities miss is partnering with their vendors.
Yeah.
When you work with an organization like Senni, then there is more to it than just buying the product. There is a support network that comes along with it. There is helping you build the systems and the processes with, and Deanna, obviously you can talk to this better than I can, and Michaela, but I have found that there's opportunities to build systems and processes to engage your CNAs in being a part of that system and that processes and having a real voice in it. And I think if you could build that infrastructure, that might help you when you have the turnover of the administrator, because you haven't relied on them being the decision maker. You've had a whole team involved in it, and you have a partnership.
Right.
It's more than just buying and selling a product. There can be so much more to it, but I think a lot of organizations don't take advantage of that, whether they don't even realize that that's an option. But I think it's vital in long-term care.
Yeah, when I was a director of nursing, it was a 65 bed facility, and I was there for quite a long time. But my CNAs, I tried to empower them whenever I could, and they actually ran the incontinence program. And we would have the vendors, come in a couple of times, at least a couple of times a year, if not more often. If we got someone that we were just struggling with and we couldn't quite figure out like which product they should be in, we'd call them up and engage, but it was their program. They ran it. I basically, didn't have to do a whole lot, and it gave them, it made them feel good about what they were doing. And, they really got to know the residents really well, even if it wasn't a resident that, so I had people on the day, PM and night shifts. So, they all might know somebody a little bit better, but they got to know them all much better. And they really had a good time with it.
Well, you sound like an amazing administrator, Tony.
Well, I don't know about that. I'm not perfect by and large, but I did know that in order to accomplish what I needed to accomplish, I had to have their buy-in.
Yeah, it makes so much sense. And Deanna Mahale, I don't know if you want to comment about the piece about, getting vendors more involved. I mean, that part is huge.
Yeah. I'll just
Go ahead, Diana.
Oh, I'm sorry, Michaela. Go ahead. Go
No,
ahead.
go ahead.
Oh,
That's okay.
I was just going to share, as you were talking, Tony, just a quick true story that's I get a chill when I think of it. So we work with a skilled nursing chain here in Florida, and we did a pilot program, and they liked the products. They were having some issues with skin breakdowns. And that pilot program rippled out from, okay, let's do some business here and bring your products in, and the product training and measuring and all of that. Well, that rippled out to all of their facilities throughout Florida. And two parts to this story. One of them being that we just had a check-in meeting that we do periodically. And our person there, who's in administration, said, I got to be honest, this is going to be a quick meeting because we're not having any issues. This is easy, so, and they had gone from issue after issue after issue after issue. So my point being, when you have a quality product, you're going to eliminate, and what's that value? I know for this particular gentleman and his team, that's a lot of value that he doesn't have to here. But one of the things we brought up to him, and I get chills when I think of this story, because this to me is what it's all about. And we actually do some advertising, and I talked to Michaela, and we're talking with this particular group to say, we just want to take this article, this letter that we wrote to you about this person, I'm going to share with you, and put that for the article. There's no need to recreate, because this sums it up. But true story, we did some measuring of a particular nursing home, and their central supply person who does their ordering also is a CNA. So if they have a shortage, so she's cross-trained. Now you start to put the pieces together. Is that something that should be looked at? We went in to do some measuring for them, and it was probably 9 months ago, maybe a year. It was a while ago when we first started with this particular nursing home. And I held the clipboard because I'm not clinical, but we brought in an LPN, and they went around with this particular girl. And we did measuring, because what you find in a lot of the nursing homes, right, is somebody who's a medium in one brand, they switch brands, or they're out and they take it from someone and medium becomes a small, and it's a whole nother set of issues that has to be addressed. But anyway, we did the measuring, and she pulled me aside at that time and she said, can you help me? We have a patient that stays in bed every day because she's severely incontinent. She's not going to change over to Seni. It's patient choice, resident choice at the end of the day, but maybe walk her through some of the benefits. And I went in, and I remember this woman because she had a beautiful view, and she was very nice and engaging, but she was very clear, and she had all her faculties. And she said, Deanna, there's no hope for me. I'm in this product. I can't get out. I'm severely incontinent, so forth and so on. And I said, well, I understand. I said, you know, it's your choice, but we're new to the market and this and that and all the stuff. If you want to try, we'll keep working with you. It's not one size fits all, and give it a shot. Just try it. Just try it. Nope, not going to try it. That's fine. We walked out, and this CNA said to me, you know what, what do you recommend? I said, well, here's what I recommend. I gave her my recommendation. She said, can you send me some samples? I said, yes. Sent the samples. Fast forward maybe 3 weeks later, 4 weeks later, the CNA called me and she said, Deanna, she actually tried it, but she thought it was too small. Can we try this size? And to make a long story short, we went back and forth for several months of try this, try that, try this, try that, try this. Very easy on our end. It's a matter of an email. Can you ship out this? So there's no issue on our end. There's really minimal time on the CNA's, and she's working with these folks anyway, if you keep perspective. But they called me back within the last couple of, I think it was in January. So it was a few months ago. They said, we've got all new staff and we're having some issues here. Can you come back in and do a training? That same CNA pulled me over that day and she said, do you remember Mrs. So-and-so in this room? And I said, the big, beautiful window looking at, I said, I do. She said, do you know, Deanna, that she came up to me, meaning her, she came up to me and she said, you changed my life. I get out of bed now, and the family came up to the CNA and said, you changed our mom's life. She's happier. She's in the Seni product. And, you know, part of it is Seni. Yes, I love Seni. I'll be Seni all day long, right? Part of it's the product. But the other part is, if you don't have a caregiver willing to take the time to implement, you can have the best product. If it just lays there for no use, it doesn't matter if it's good or bad. It's the other part. And I got chills talking to her because I said, oh my gosh, her name's Ginger. I said, more people, Ginger, need to be you. We need more Gingers in the world that kept, try it. Don't push it, try it. Get her comfortable, get that trust factor, which is huge. And that woman, and you look at, if that was my mom or dad, that's a big deal. That's all that matters to me. It's my mom, my dad, or whatever. So I think almost that messaging, and we're, you know, working with them now to say, look, we just want to take what happened. That when we shared this, they said, oh, we've got this award for, you know, what employees do right when no one's looking. Can you send us? So I wrote it up, and then it happened that we got advertised. Mihaela and I talked. I said, why are we going to reinvent the wheel? This story has all the elements of what we want to convey. Let's just take the story and plunk it in this particular publication. So we're hoping to be able to do that. But I think if people heard more positive stories about life and dignity and confident and I'm up and about versus fecal, feces and urine, your head goes like this, but life, we go like this, right? So it's like, I think more stories have to be shared to be positive of what the difference is from not only product, but implementation is huge.
It's that combination. I mean, that's what you hit on, Deanna. It's that combination. And I know that we only have a few minutes left and I want to respect everyone's time. So I just want to say a couple things. You know, Tony and Donna, Seni's and Dr. Laird are going to be doing a webinar for us on, Joan, you told me and then I forgot, May 6th. On May 6th. That we're going to be presenting. And one of the reasons we wanted to do this conversation before the webinar is to get more of an idea of what people want to hear about and talk about. And Donna and Tony, I think you've given us some ideas. Wouldn't you agree, Dr. Laird and Mihaela and Deanna? about maybe
Definitely.
more of a focus on what we should concentrate on. And also, maybe you could help us get some of your QIO team members across the country, and your nursing homes to be on this webinar, because we could try to tailor it a little bit too. And we could continue to have some email conversations if you have some suggestions. So we're really open about that idea.
I just want
Definitely.
to throw in there, I liked the reminder that they should be partnering with the vendors, because that is the other piece where I don't think that, when you were talking about the small, medium, large closet, right? I think that there's a lot that they don't remember, that there's a fitting that needs to happen with the product. Otherwise, they still could have issues with incontinence and not be able to enjoy their lives. So thank you for that reminder as well. But there's definitely, I think the QIOs would be interested in promoting this with their centers. I can't wait to read through this white paper and to see how we might be able to use it. Is it available and out for the public already, or is it something that's not released yet?
Yeah, go ahead.
So I was just going to say, we have it for you folks here, and then as of April 1st, and we would love more help in promoting it, but we are going to put it out through McKnight's Senior Living, and it's going to be out there for a month as one of their sponsors, where they can click in, the general public can click in and get a copy of that white paper.
But I think it's no problem if you want to, distribute it to your colleagues and things like that. So feel free to share it with everyone that you need. We just officially we will, release it with McKnight's as well. But feel free to share it.
When it's released with McKnight's, I'm going to make sure that there's a link in our newsletter that goes out so that everybody can click on it and get it. But I'll share it with my colleagues right now.
That would be great. And I think that the other thing is, just so you know, that May webinar is going to be free as well. So I think that, for the QIO teams across the country and for the nursing homes that you support, that could be great. And also feel free, and Joan, could you put the link to the podcast in the chat as well? Feel free to share the podcast with your QIO colleagues and the nursing homes you support too, because there's a lot of great information in there, and that's something that people can listen to at any time, so just please feel free to do that. So
and I will just mention that link may change tomorrow when we actually get everything up on the site, when we get this conversation up on the site as well. But I will send something to everyone who was registered for this discussion so that you will have the current information.
Yeah, and we can send as well, the podcast is already on our YouTube channel. So that link for sure is going to be all the time the same. So it will not fluctuate. So
let's send that one out as well.
Yeah.
Joan, okay. And that would be great, because that's a great idea, Mihaela. Thank you for that.
We have a newsletter that's set to go out next week, so I can make sure that as much as I can of this gets out in that e-blast.
Oh, good. For your newsletter, Tony, Mihaela, let's send out your YouTube link for the newsletter. I think that would be great.
Okay. No problem.
Oh, cool. Okay. Well, good. Well, Donna and Tony, thank you so much for joining us. And Dr. Laird and Mihaela and Deanna and Joan, thank you for joining us too. And Donna, I know you have to jump off. One more thing I want to say is we do have episode 4 of our Listen, Learn, Explore series coming up, and it's going to be about using outdoor space. I feel like these are my soapbox. Incontinence has become my soapbox, and now the use of outdoor spaces is too. And that's going to be with Maggie Calkins and then Matt Richardson from Whisper Glide. So more information, obviously you're on our email list. And so thank you, everyone. This has just been a great discussion, and I have a feeling we're going to be in touch with all of you more.
Thanks so much.
Thank you so much.
Thank you.
Thank you.
Bye-bye.